Hello and welcome back to AP Psychology. I'm Miss Lee and we're still in Unit 8, Clinical Psychology. This video will be focusing on personality disorders and dissociative disorders. Our learning targets are similar to our previous video, except for we will be focusing on personality disorders and dissociative disorders instead of those other disorders. If you haven't done so already, go ahead and grab your notes. So let's talk about personality disorders first. Personality disorders are long-standing, inflexible personality traits that impair social functioning. So we've talked about what traits are, and these are traits that impair social functioning, and there are three clusters. Cluster A exhibits odd or eccentric behaviors. Cluster B exhibits dramatic or emotional traits, and Cluster C exhibits anxious or fearful behaviors. Often people with personality disorders seek treatment at the insistence of others, such as a court order or through the pressure of a family member, because the individual isn't generally distressed by his or her condition. That still qualifies as a disorder, though, if you will remember that the distress can be experienced by others. Let's start with Cluster A. An example of Cluster A personality disorder is paranoid personality disorder. This is characterized by paranoia and a pervasive, long-standing suspiciousness and generalized mistrust of others. Schizoid personality disorder is a pattern of indifference to social relationships with limited range of emotional expression and experience. This disorder manifests itself by early adulthood through social and emotional detachments, and this prevents people from having close relationships. So these people are generally seen as loners. And then you have a schizotypal personality disorder. This is characterized by a pattern of social and interpersonal difficulties that includes a sense of discomfort with close relationships, eccentric behavior, and unusual thoughts and perceptions of reality. Patients usually experience distorted thinking and behave strangely. They also avoid intimacy. So it's in some ways similar to the schizoid personality disorder, but the schizotypal disorder is going to include eccentric behaviors as well and unusual thoughts and perceptions of reality. Honing in a little bit on the paranoid personality disorder, individuals with this disorder display pervasive distrust and suspicion of others. Common beliefs include the following: that others are exploiting or deceiving the person, that friends and associates are not trustworthy, that any information that's confided to others will be used maliciously, and that there's hidden meaning in remarks or events that others perceive as benign. So it's like they almost see secret code or something within hidden meaning from remarks. And they also can believe that the spouse or partner is unfaithful. Cluster B. So we have a couple of disorders that I want to highlight here. You have a borderline personality disorder. This is marked by an ongoing pattern of varying moods, self-image, and behavior. These symptoms often result in impulsive actions and problems in relationships. Histrionic personality disorder is characterized by a pattern of excessive attention-seeking, strong emotions, and this is usually beginning in early adulthood. It can include inappropriately seductive behavior and an excessive need for approval from others. Narcissistic personality disorder is characterized by a long-term pattern of abnormal behavior that's characterized by exaggerated feelings of self-importance and also an excessive need for admiration, also a lack of empathy. And then we have antisocial personality, and we're going to dive into that in some detail in just a moment. But first, borderline personality disorder. Again, this is a pervasive pattern of unstable and intense interpersonal relationships, self-perception, and moods. Impulse control is markedly impaired. This is basically one of the characteristics of Cluster B personality disorders. Diagnostic criteria includes at least 5 of the following, can be more. Frantic efforts to avoid expected abandonment. They anticipate being abandoned, and so they do whatever they can to avoid that. Unstable and intense interpersonal relationships, markedly and persistent unstable self-image, impulsivity in at least 2 areas that are potentially self-damaging, recurrent suicidal behaviors or threats or self-mutilation, affective instability, and this is regarding your affect or how you express emotions, mostly on your face, but it can be throughout the entire nonverbal communication, chronic feelings of emptiness, inappropriate and intense anger, transient paranoia or dissociation, so it comes and goes. We now get to antisocial personality disorder. This is probably the most well-known personality disorder. Clinical features of APD must include at least 3 of the following. Often there is more. In this person, you see a lack of conforming to laws, evidenced by repeatedly committing crimes, repeated deceitfulness in relationships with others, such as lying, using false names, or conning others for profit or pleasure. So this is your con artist. There's also a failure to think or plan ahead, so impulsivity. There's a tendency to irritability, anger, and aggression. This is shown by repeatedly assaulting others or getting into frequent physical fights. And there is a general disregard for personal safety or the safety of others. This disorder cannot be diagnosed until the individual is 18 years old, but to be diagnosed with APD, the individual must have shown symptoms of the diagnosis since about the age of 15. Usually the individual has been previously diagnosed in childhood with conduct disorder. It does occur more often in males than females, and sometimes you'll see the terms sociopath or psychopath in relation to APD. Some studies have suggested a genetic predisposition to APD, so possibly in the form of chronic under-arousal of both the autonomic and central nervous system, which leads to abnormally low anxiousness, which can make people less sensitive to punishment. So generally speaking, they don't receive the same rush, the same anxieties, the same autonomic nervous system responses to certain behaviors that others see as deviant or frightening, and so they're constantly pushing the limits of those behaviors. Other research has linked an underdeveloped amygdala to APD. And if you'll recall, the amygdala is the emotional center of the brain. So if you don't experience a lot of emotions, that can lead to some serious problems. If you don't have any emotional attachment to things or people, then you don't regard them very highly. Other researchers believe that environmental factors like broken homes, rejection by parents, poor discipline, lack of good parental models, lack of attachment to early caregivers, impulsivity, conflict-filled childhoods, and poverty play a role in the behavior exhibited by antisocial individuals. When it comes to understanding the physiology of APD, researchers have looked at the PET scans of 41 murderers, revealing reduced activity in the frontal lobes, had 11% less frontal lobe compared to the brains of normal individuals, or what is considered normal. And if you look at the scans on your screen, to the left you have a normal brain, quote unquote, and then the brain of a murderer to the right, and you can see some definite reduction in the activity of the frontal lobes. We will talk about conduct disorder and oppositional defiant disorder when we get to neurodevelopmental disorders. Because these disorders occur in children, they are not and cannot be considered personality disorders. However, you need to know that there is some type of a relationship. It's not cause and effect, but we do know that children diagnosed early in life with conduct disorder and oppositional defiant disorder can sometimes go on to be diagnosed with antisocial personality disorder, but that is certainly not always the case. It's more that the opposite is true, that antisocial personality disorder tends to see more incidents where conduct disorder and oppositional defiant disorder are seen in early ages. And there's a difference there. Finally, we get to cluster C of personality disorders. You have avoidant, which is characterized by feelings of extreme social inhibition, inadequacy, and sensitivity to negative criticism and rejection. This causes significant inabilities to maintain relationships in day-to-day life. You have dependent personality disorder, which is characterized by an inability to be alone. And folks develop symptoms of anxiety when they're not around others. They need constant reassurance from others to function. And then you have obsessive compulsive personality disorder, which is very different than OCD. This is characterized by a preoccupation with orderliness, perfectionism, and mental and interpersonal control. This tends to be at the expense of flexibility, openness, and efficiency. So people who just really, really like neatness and orderliness and tidiness do not necessarily have OCD. They more likely have obsessive compulsive personality disorder, but only if it affects their day-to-day life. A lot of times people misuse the term obsessive compulsive disorder when they really mean that a person just super likes being neat and tidy. Okay, so let's talk about dissociative disorders. Dissociation has sometimes been described as being like daydreaming or getting lost in the moment while working on a project. If you've ever gotten into the flow of something, you really lose time and kind of sense of what's happening around you. It's characterized by a separation of critical parts of the personality, such as memory, consciousness, and identity. And these are the parts that are normally integrated and work together. Temporary dissociative states are common for most of us. For example, when you're driving a common route, you drive that route every day, like going to school or work, and you realize you don't recall going through an intersection or whether or not you even stopped at a stop sign. You have dissociated. You have temporarily separated from yourself. Dissociative identity disorder was previously known as multiple personality disorder, and this is a condition in which a person appears to have two or more distinct personalities, each of which can speak, act, and write in different ways. These different identities also seem to have their own memories, wishes, and impulses. Often the impulses of one identity are in conflict with those of the other identities. Problems occur because there's only one body available for the different personalities, and this forces the personalities to take turns. And because there can be strong variations in the personalities, a person's behavior, when looked at overall, can appear very inconsistent. In the book Breaking Free, former NFL running back Herschel Walker delves into his excruciating struggles with dissociative identity disorder, saying he tried to manage a dozen personalities throughout his life. The case of Chris Sizemore was made into a movie back in the 1950s. The name of that movie is The Three Faces of Eve. 3 of Chris's 22 distinct personalities were depicted in the book and movie and referred to by doctors as the meek, bland Eve White, the dominant and carefree Eve Black, and the mature, intellectual Jane. Another famous case of dissociative identity disorder was the case of Shirley Mason, or otherwise known as Sybil. In the early 1950s, Mason was a substitute teacher and a student at Columbia University. She had long suffered from blackouts and emotional breakdowns and finally entered into psychotherapy with Cornelia Wilbur, a Freudian psychiatrist. Their sessions together are the basis of the book Sybil, which was later made into a movie. Mason later moved to Lexington, Kentucky, where she taught art classes and ran an art gallery out of her home for many years. What's interesting is the 2 pictures on the right were made by different personalities of Shirley Mason, and you can see that they are very distinctly different. So there were many, many personalities that were documented of this case. I would recommend that you pause here and kind of take a look over the different personalities. There were quite a few. Through therapy, Shirley was able to kind of pinpoint when and how each of these personalities were born. So let's talk about the development of dissociative identity disorders from the different perspectives. The psychoanalytic perspective believes that a massive repression of unwanted impulses or memories basically create a new person who acts out otherwise unacceptable impulses or recalls otherwise unbearable memories. So this can be born from trauma, and the personality that is born basically takes on that unwanted trauma and serves as almost an offshoot of the original personality to protect it. Behaviorists believe that everyone is capable of acting in different ways in different situations, and this disorder is the extreme variation of acting so different that you feel like a different person. Also, the symptoms are often strengthened by the reward that memory loss or shifting personalities allows an individual to escape stressful situations. So it's reinforced. Evaluating the true causes of DID has been very difficult due to the rarity of the disorder or the rarity of individuals coming forth with symptoms of the disorder. However, most clinicians believe that the root cause of the disorder is some sort of abuse or trauma during childhood. Basically, the child separates themselves from the abuse or trauma as a way to deal with the situation, and they continue to do it throughout the rest of their lives because they learn in some way that this is an effective way of dealing with trauma. There are some psychologists who do not believe that DID is an actual disorder. They believe the individual may be a con artist or simply role-playing to ease anxieties in his or her life. And that is it for personality disorders and dissociative disorders. In our next video, we'll be continuing specific disorders in clinical psychology. I can't wait to see you then. Bye for now.